All right, good morning. I think we're going to go ahead and get started with our session. So obviously, thank you for everybody for getting here on time and early. I got some housekeeping things I'm going to try to read off here real quick. Today has a full day of program. Some highlights we want to emphasize here. We have the international panel, representation from Denmark, France, and England. Very Eurocentric here. That will begin at 9:45 a.m. We have a distinguished visiting professor lecture by Charlene Grabowski, What Makes a Great Leader. That's going to happen in this room at 10:45 in the morning. After the distinguished visiting professor, there's lecture. There's three exciting lunch symposia today from 11:45 to 1 o'clock, sponsored by W.L. Gore and Associates, Medtronic, and Penumbra. And then in the afternoon, we have the first round of the Carmody poster session. That'll happen at 2:30 p.m. at the Moon Tower Hall. And today is the last day to visit our exhibits, so please take some time to go to the exhibit hall and talk to our industry sponsors, and thank you for their support. And tonight is the attendee reception at the Zanzibar, which is a restaurant on property, and everybody's obviously invited to attend. So I think we're going to go ahead and get started with our session.
All right, first speaker, this is an invited talk on our Disparity Committee came up with several topics that I thought were important, and the first talk will be strategies to mitigate peripheral artery disease disparities. Will be presented by Dr. Olamide Alaba. I'm sorry if I'm mispronouncing your name, from Emory University.
Hi, good morning, everyone. Thank you for the invitation. My name is Olamide Alabi. I am a vascular surgeon in Atlanta at Emory, and I was asked to give a 5-minute talk on one of what I think is one of the largest issues in peripheral artery disease care and outcomes. So either buckle up, or I guess maybe the mic will turn off in 5 minutes. So no disclosures. Have you ever thought about the number of publications that there are related to disparities in care in peripheral artery disease, specific to outcomes? Well, there are a lot. They span decades, and they've always shown the same thing. Black and brown patients have 2 to 4 times the rate of amputation compared to other patients. And a lot of organizations have called for an elimination of this problem, et cetera, but what I can say is largely not very much has been done. So I think it's really important that we acknowledge, number one, that there's a problem, and also try to better understand what the actual issue, the underlying issue is. So what are the real drivers of health inequity in this space? I think probably everyone in the audience is familiar with the term social determinants of health, I presume. So I won't spend very much time on that, but I will clarify one thing. Race is not a social determinant of health. Racism or racial discrimination is. So that's an important clarification to make. I'll spend a little bit more time on the political determinants of health. I think that's probably something that people have a little less familiarity with. The political determinants of health are the exacerbators, perpetrators, the things that have these structural conditions that have been created and have fueled health disparities to this day in peripheral artery disease as well as other disease states. So think of this as in the 1600s, there were these facially discriminatory policies that were created by lawmakers, business owners together, and they kind of created these situations where people were told where they could work, eat, write, if they could learn to read, where they could play, where they could do anything, really. And these policies also said where highways were built, where factories that have hazardous waste or air pollutants go, where fast food restaurants nowadays go, where a Whole Foods is not likely to be placed, and where people like me live, who phenotypically look very similar to me, live in relationship to those things. So that encompasses the political determinants of health. We don't like to talk very much about bias because it feels like almost like a personal attack, right? So people like to stay away from this topic. But I would say that we need to challenge our implicit biases in particular so that we can better understand what those implicit biases are and then combat them. Some of them in peripheral artery disease can look like guideline-directed medical therapy. So we know that statins save limbs and save lives, but everybody doesn't get statins. Why? We don't know. Particularly if you're black or if you're brown, you're less likely to get a statin. Similarly, we know that structured exercise therapy along with guideline-directed medical therapy is the standard of care for patients with claudication. But a lot of individuals don't get this. You say that's a global problem for claudicants, right? But even more so, black and brown patients are less likely to get exercise therapy for their claudication. And the list goes on and on. So let's talk about ways that we potentially can fix it in a couple minutes. So again, I think it starts with acknowledgement. A lot of other people get it, and we need to, as a field, better understand it and get it as well. Everybody else is kind of calling us out. We kind of need to get on the bandwagon and figure this thing out. As it relates to research, I believe that there's a debate later today specific to this topic, so I won't belabor this point, but I would say when it comes to disparities research, it's really important to understand that disparities research is not just finding differences between different groups and then publishing a paper. Disparities, by definition, are preventable differences, not just differences. So important to keep that in mind. Community engagement and cultural competence. I think it's really important that people feel as though they are in a space where they can belong, in a place where they're going to receive the care that they deserve from the moment they walk into your office. And that starts before they even meet you, right? That starts at the front desk. That starts with the MA or whoever's rooming the patient. That starts with the vascular lab technician who greets them, et cetera. And trying to make sure that the space where these people are receiving care is one where everybody's on the same page, everyone's making sure that the patient is getting the care that they deserve. Policy change and community partnerships. There are a lot of novel community partnerships that myself and others in the room have created over time to better understand what policies exist and what policies perhaps can exist to better move the needle on this disparities problem specific to peripheral artery disease. And then combating bias. Again, the thing that we don't really like to talk about. Implicit bias has been found to be associated with proceduralist behavior. So Corey Kalbaugh, he's a vascular surgery specific epidemiologist. He presented this work at the American Heart Association, and it was recently published in JAMA. And effectively, what he found is that physicians with white specific preferences were more likely to perform a below-the-knee procedure in their black patients with claudication. And black patients treated by physicians with white implicit preferences had worse one-year amputation outcomes. These are claudicants, worse one-year amputation outcomes. So again, implicit bias can drive the way that provider behavior occurs, and those are things that we really have to combat head-on. And the workforce. I'm sure you guys have seen these numbers or can imagine these numbers. The workforce does not represent it's not representative of the population in which we live. And there are a lot of things that need to be done about that. Dr. Velasquez will be speaking a little bit more specifically about training, but I think it's important, to take a chance, if you will, you can use that term, to hire a black or a brown or et cetera trainee, to hire them into your practice and to train them up as younger individuals as well.
Thank you very much. I'm sorry you had to rush through that. I made changes to the program, and we're trying to encourage discussion, and so the talks are all short, so I apologize. So if you, is it possible, I'm working with the Louisiana Department of Health and our local Department of Health, if you had kind of an unlimited budget and could tackle an area like Atlanta or New Orleans kind of globally, is there a way to do that, or are all these problems, with the individual providers?
Yeah, I don't have enough time to talk about that, but but what I would say is, yes, it is possible. I think it's really important. A lot of these studies have either been single center or national data, and it's really important to understand what's happening in your own backyard. It's very different for Atlanta than it is for New Orleans, that it is for somewhere in New York, et cetera, et cetera. So what we are specifically doing is looking at the procedural behavior in the state of Georgia, so we can better understand. I should mention, just for some background. Congressional District 2 in the state of Georgia has the 11th highest amputation rate in the country. So that's important, right? That's in our backyard. It's not Atlanta, but it's just outside, essentially. So I think it's really important to understand what's actually happening in your state. Where do the quote-unquote, I see Dr. Humphreys, where do the quote-unquote vascular deserts exist? Where do the podiatric deserts exist, et cetera? And make sure that we can galvanize resources so that we can get patients the care that they deserve.
Yeah, absolutely. As soon as I started seeing some of the early disparities research which used area deprivation index, I kind of cringed a bit because one, I knew it's super easy to get, so people are going to use it, and two, that's not New Orleans. Like, we don't have those type of zip code situations. Just the way it raised up from like plantations to basically former slaves living on the same spots where they were once slaves, and so it's much more heterogeneous than that. So I was trying to, get past that to figure out what it is, and I'm trying to nail down that maybe it's, the timeline of these patients and who's seeing them, and like you said, podiatry, it's early recognition that there's a problem, I think is the problem, but we're not there yet, so, thank you. And if there's other questions, right, Misty?
Oh, yeah.
I think while she's coming up with a question, I think just that's a very important point to make. A lot of people will say, well, a lot of these outcomes happen because people show up too late. And what we have found in a lot of the data sets that we have been mining, whether it be VA administrative data, single center data, or data within our region, a lot of individuals are plugged into healthcare. They may not be plugged into a vascular surgeon or a vascular procedures who can actually help them with the problem, but they are trying to get the care that they deserve. They're just not getting routed to the people who can give them that care.
Yeah, absolutely.
So Misty Humphreys from UC Davis. Thank you, Dr. Alabi, for this talk. I wanted to ask you a little bit about how we should be partnering with other organizations. So they're plugged into healthcare. So why is it that their healthcare providers are not providing them with some of the care that they need? And how do we as an organization actually bridge that gap? I know the American Heart Association has the PAD Collaborative, and there are other collaboratives that are coming out, but I think that this is more of something that as organizations we can partner with internal medicine, family medicine groups. And how do you see that working?
Yeah, so great question. I think it is really important. Why are people not getting to us? A lot of these other specialties don't know. They don't know about peripheral artery disease. And then when you ask them to do things that you think on your end seem very simple, like, could you just have your MAs or your LVN or your NP, or, whoever do an ABI in the office? And they're like, no, we don't have time for that. We have all these buttons we have to click, blah, blah, blah. And I get it. I completely understand their burden, their administrative burden is much higher than our own in the clinic space. So I think that I think it is important to partner with other specialties as well as organizations. One way that we have done so is on the VA side of things, there is a program called Tele-Eye Care Services, TECS. And these are individuals who go out to community-based outpatient clinics, so these clinics that are out in rural areas in Georgia and in Alabama, and they do eye screening exams. And I thought, well, these individuals have very similar risk factors to patients with peripheral artery disease, so why not just do a foot exam while they're getting their eyes screened? So we taught the TECS tech to perform a podiatric foot exam, and then now so that has already been rolled out, and that's at all of our tech sites within the region now. But then we also are including training the techs how to do a pulse exam and then an ABI.
So Olamide, great presentation in a short time. So my question has to do with ourselves and the implicit bias issue. So have you dissected down a little further as to why those who have implicit bias are having a worse outcome? Are they not doing procedures? Are they not prescribing? And what can we do to fix that? Because obviously we want to fix ourselves. That's something that we could potentially change if we realize we have a bias. So what aren't we doing, or what are we doing wrong? Thanks.
Yeah, again, great question. I think so it's new for us as vascular proceduralists to know that there is an association between implicit bias and the behaviors in which we're providing care to our patients. I think that we need to challenge, what we're doing. So what can it look like? If we want to improve care for patients, we know that it starts with, for PAD patients, it starts with guideline-directed medical therapy. That's an antiplatelet agent, and that's statin therapy. And if all your patients aren't on it, you got to ask the question, why not, right? So I think it starts with that. I think also, when we treat these patients with chronic limb-threatening ischemia, we, in training programs across the country, we have been taught these individuals need inline flow in the first procedure. To be able to combat, whatever the problem is. They need a toe amputation, they need to heal a wound, they need to get rid of the rest pain, whatever the case may be. But there are a lot of individuals, particularly if you're Black or brown, who are not getting inline flow for their CLTI in the first procedure.
Right. Dr. Alabi, thank you very much. Very important topic, and thank you for your insight.
Thank you.
I'm going to call the next speaker up. I believe it's going to be Dr. Thomas Serena. The title of the talk is Pilot Implementation of the Vascular Surgery and Trustable Professional Activities. Obviously, EPAs are very important in vascular surgery training, so looking forward to hearing some of this.
Thank you for the opportunity to present. Multiple authors are writers and members of the EPA Writing and Advisory Committees. This is our only disclosure. Entrustable professional activities describe certain competencies that can be entrusted to trainees that demonstrate they can achieve or perform a given task. This is a forward-thinking and progressive assessment. Not what did the trainee do well this time, but what can they independently do in the next encounter. EPAs have been adopted within the United States medical education to increase learner feedback in a time-efficient and workplace-based manner. The ACGME published the initial 2-year pilot program of EPA assessments in general surgery training in 2019. Their data provided evidence that EPAs could be successfully implemented in general surgery training programs and provide meaningful data regarding the benefits to both trainees and faculty. In 2021, the Vascular Surgery Board, in partnership with the Association for Program Directors in Vascular Surgery, established an EPA council charged with development of EPAs for vascular surgery, defining the core activities on which a vascular surgeon must achieve proficiency in prior to entering unsupervised practice. The goal was to create a system of feedback that is both quantitative and qualitative. Through an iterative process, a trainee begins to understand where they are succeeded and where they can improve, as opposed to a delayed interval feedback. We sought to explore the feasibility, utility, and acceptance of vascular surgery EPAs across a national cohort. An expert writing group came up with 15 core EPAs that would be stratified across pre-op, intra-op, and post-operative phases, and crossed with both open and endovascular procedures. These 15 core EPAs were graded with expected behaviors for differing levels of entrustment in a manner to reflect the ACGME milestones. All programs voluntarily participated in the national pilot. All workplace-based assessments on the EPAs were presented through various applications, most commonly the SIMPLE application, and then collected using the ABS EPA assessment application. A summary report of assessments was provided by the ABS after extraction from Qualtrics, and researchers reviewed open-ended questions. 30 sites were included in the pilot. 20% of these sites were community-based programs, and 80% were university or academic hospitals. The post-pilot surveys were completed by 89 participants, including 22 program directors, 26 trainees, 28 faculty, and 13 program managers. 1,662 unique clinical encounters were assessed through the ABS EPA assessment app, with 3,324 EPA assessments assigned and 2,746 completed. This was a completion rate of 83%, which was very good. Faculty completed trainee-initiated EPA assessments 59% of the time, and trainees completed them 61% of the time. So again, for a pilot program, excellent response rate. The most commonly used phase of care was the intraoperative phase, representing 85% of all completed assessments. Dialysis, access, CLTI, and cerebrovascular were the most common categories, and aneurysmal disease, aortic disease, and mesenteric interventions were the least common. When examining faculty perception of EPAs, 83% felt that they took an appropriate amount of time to complete, and 74% felt that the EPAs helped them to identify topics on which to provide feedback. 96% of faculty believed that they covered the core activities of vascular surgeon. So they were quick to do, they helped them give feedback, and they were appropriate for what they needed to do. When evaluating training perception of EPAs, 85% of trainees agreed that they were comfortable initiating EPAs. 77% of trainees felt that the day would help them to set learning goals and to identify areas for improvement. And 92% again believed that they covered the core activities of a vascular surgeon. So again, they're comfortable initiating EPAs. They helped them to set learning goals, and they identified areas for improvement. Lastly, when evaluating how EPAs fit into clinical workflow, the overwhelming amount of participants agreed that it was easy to integrate EPA self-assessments into OR, clinic, and ward workflow. EPAs will be implemented on a national scale in August of 2025. There will be no formal requirement, but the goal is to have progressive engagement and further study the ability of EPAs to optimize surgical education. This study demonstrates the feasibility and acceptability of EPA assessment implementation across vascular surgery. In addition to a high level of engagement, the post-pilot surveys identified positive appraisal for the implementation, and the future implementation will be happening on a national level with an ability to progress and optimize surgical education. Thank you.
General surgery has a little bit of a hard time implementing it. Did you guys ask what were the barriers to implement this?
Yeah, so one of the first barriers is actual education. It was interesting because the program directors felt that there wasn't enough education that was provided, but faculty and residents, trainees, fellows, they actually felt that they did have enough education in the background to allow them to do that. And then also one of the big barriers was the application itself, familiarity with that, and that's something that's going to be fixed in the next round where they standardize that.
Dr. Mitchell?
Great, great summary of what's coming out. My recommendation is to make this easy for everyone, because what you didn't highlight was that there was a decline in the response in putting back, resubmitting the EPAs with time. Everyone's burdened with all this, and just make it easy on everyone.
Yeah, thank you.
Dr. Humphries?
I'll just continue with that question or that thought. How is this different than, say, the milestones? And how do the milestones incorporate in this? I use the milestones, I sit with my trainees, I go through them, I encourage them to look at them so they can see where they are and where they need to be. And yet still, I get responses that there's not enough feedback. I talk continuously in the case. I ask them what they learned at the end of the case. I could not be given more feedback, and yet they need more. So how much more do I need to give, and how do I need to give it to make it to where it seems to be effective?
Yeah, I think that is a really, really great point. So the goal for EPAs is that they will be inclusive of the ACGME milestones, but they're going to be delivered in a way for participants that they're receiving them on, say, an iPhone application. And as silly as it sounds, there's a difference between having it in an application on your phone every single day and having it that's going through an email or through something you need to log into. So the manner in which they're receiving them and actively receiving them after every single case, that's what the difference is. ACGME milestones is more of a interval feedback. While sometimes we have faculty preceptors that are fantastic at giving us that constant feedback every single case, talking through that, the perception of a trainee that they're actually receiving that is different. Whereas in EPA, you're getting it after every single case. So it's a continuous workplace-based manner after my intervention. What did they think that I was trustable with, and what do they think that I need to work on?
Dr. Garani?
So just a question, after we implement this, we go through the education, we train all the residents, we train all of the fellows, we train all of the faculty to do this, and we implement this successfully and we get through all the issues that we have to get through, how do we take the results of this and reassess it to make sure that it actually changed the education system? So what's the positive feedback loop to reassess what the changes that we made to make certain that we obtained the goals that we wanted? Better quality, better training, better outcomes for our trainees?
Yeah, I think that's another great question. The best thing that we can do is have longitudinal research that shows that this continues to make trainees feel like they're receiving positive feedback in a timely based manner. I believe that the ACGME survey, like your ABSITE surveys and your VSITE, do incorporate some components of the feedback on how trainees believe that they're receiving, and the yearly survey that they get through ACGME as well. And so I think a good idea would be to kind of put that on par with how did trainees do over the last 10 years and how are they going to do in the next 10 years moving forward.
Last question, Dr. Harris.
So more of an operational question. We've been using the Simple for a number of years, and one of the problems we see is that the trainees like to give or ask for the evaluation when they do a case well, but when they're struggling, which is when they really need to submit the case, they don't like to do it. And so how do we ensure, if we're going to use the EPAs, that's really reflective of their abilities and their knowledge, rather than, I need a pat on the back, I did this one really well? Thanks.
Yeah, and I think the opportunity within the application is that trainees can initiate an EPA or faculty can. And I would probably argue that it is exactly what you said. A trainee is more likely to initiate it when they crush a case, but I think a faculty is more likely to initiate one when a trainee does not do well. And so I think it's coming from both ends of the street.
I'm a surrogate senior author, sorry. So just to fill this in, there's two really important aspects that we learned from general surgery. The first is that you need a champion faculty member at your site. So someone who will say every month, okay, we're starting to drop off, we need more, and we need to keep doing this. And the second is data. And so because this is not an end of the year rotation sort of thing, they need to be completed in larger numbers. And so you get good and bad, and then we can start to move forward with that for that positive feedback loop.
Perfect.
Perfect.
Thank you.
Sabrina, thank you very much.
I'm just going to make one comment to what Dr. Humphries was asking as a person who was involved in writing EPAs. The difference between EPAs and milestones is a big assessment, and EPAs will help us fill out those milestones, and they all map to milestones. So we sat there in the room for hours mapping it. So when you're going to do your CCC, the milestones will be filled through the app, so it's actually going to help you. But EPAs are these micro assessments that you do on a daily basis, and milestone is a big picture. But so the next paper will be presented to Dr. Park. It will be Operative Confidence of Graduating Vascular Surgery Trainees.
I think we have a little bit of a switch in the program due to traffic, so can we make sure we have the correct slide deck go up? Okay, well, never mind, traffic, we beat traffic. So we'll go ahead and read the next.
All right, then we're gonna go with Dr. Chan's presentation, Vascular Surgery Interest Group Significantly Influence Matching at Top Integrated Vascular Surgery Residencies.
Perfect. Good morning, everyone. I did, in fact, beat traffic, so I'm really happy to be here and present our work today. I'm Melissa Hsu, a second year at Thomas Jefferson, and I'm honored to be here today. Just to start, I have no disclosures. So, some background, integrated vascular surgery residencies are competitive programs. In the past 10 or so years, increases in applicant number have outpaced growth of available positions by more than twofold. Previous studies have investigated research productivity and mentorship as factors contributing to successful matching in vascular, but these have been univariate and limited in sample size. Moreover, they only investigate a candidate's individual characteristics. But other surgical subspecialties have found that a candidate's medical school characteristics can also significantly impact their matching success. Thus, here we aim to be the first study in vascular to evaluate the impact of both medical school characteristics and individual characteristics on matching. So, just for some methods, this was a retrospective cohort analysis, and we compiled a list of all the IVSRs that were ACGME accredited in 2023. Each program site was accessed to compile their current residents from PGY 1 to 5, creating a sample that was representative of all available residents from the 2019 to 2023 matches. The inclusion and exclusion criteria are as listed. Our primary outcome was whether candidates matched into a top 50, 25, or 10 IVSR. For each resident, we gathered a few covariates of interest. For medical school characteristics, it was what school they attended, that school's U.S. News ranking, which we stratified into tiers of 40, whether that school had a vascular surgery interest group, and that school's NIH funding. For individual traits, we gathered whether they attained an additional graduate degree and whether they attained AOA membership. And believe it or not, all of this information was found on publicly available sites, so our methods basically included severe internet stalking. So, our final analysis included 374 candidates from 120 unique medical schools. 95% were MDs. 11% had an additional degree, with most of those being Masters of Sciences. 16% were AOA members, and moving on to medical school tiers, we can see that though we had candidates spanning all 4 categories, the 65% of our applicants were from the medical schools in the top 2 tiers. In Table 2, here we tabulated the top medical schools with the highest proportional quantity of residents matched into IVSRs. We ran a logistic regression to identify the significant covariates for matching into top 50, 25, and 10 IVSRs. Positive predictors are marked in red here, and you can see that for matching into top 50 IVSRs, the significant predictors were coming from a tier 1 or 2 medical school, coming from a school with a VSIG, and attaining AOA membership. For top 25, it was having an additional degree and coming from a school with a VSIG. And for top 10, the only positive predictor for matching was coming from a tier 1 medical school. So to summarize, I'd like to highlight 2 main things. One is that the presence of a vascular surgery interest group had an extremely broad impact and increased the likelihood of matching into top 50 and 25 IVSRs. Medical school tier 1 is also noteworthy as it had the strongest impact in matching into a top 50 program with an odds ratio of 5, and it was also the only significant predictor in matching into a top 10 IVSR. Our study is the most comprehensive analysis to date for IVSR matching outcomes, given the breadth of covariates in our representative sample. The results suggest that VSIG implementation is a potential avenue for institutions to increase candidate interest and competitiveness for the field. As for the significance of medical school tier, this information, along with our tabulated list of top IVSR contributors, may inform the application decisions of prospective medical schools candidates who already know they're interested in the field. For future studies, it'd be ideal if we could account for unmatched candidates, as currently our entire sample is matched candidates. And also it'd be nice if we could account for other covariates that were absent from the publicly available data, like numbers of honors and clerkships, number of sub-Is, and USMLE scores. These are our references. Thank you, and I'll take any questions.
Dr. Pierce.
Why don't you take a breath for a second? My name is Ben Pierce. I'm from the University of Alabama. You got a 10-minute talk done in about 3 minutes, so I need to ask some questions because I couldn't follow all that. You did great. Don't get me wrong. What's a tier? I don't understand your tiers.
Yeah,
How
so
are you classifying medical schools?
we utilized the U.S. Best News ranking because at the time that was a valid scale. Currently, a lot of schools have been pulling out of that system, but there was about like 160 rankings, and so in order to kind of categorize them and to get some like power in our effect, we organized like 1 through 40 into tier 1, and then 40 through 80 into tier 2, and like we did tiers of 40 with that U.S.
You're saying they're
News
based
scale.
on the rankings of the hospitals?
No, it's that medical school, because we were trying to see if a candidate's medical school characteristics played into effect. So maybe if their medical school ranking was higher, it would help them get into a higher ranked IVSR program.
Sure. And then this is the number for the candidates. This is coming out of ERAS, out of NRMP data, because there's a lot more unmatched applicants if you look at the total number of
Yeah,
people who
so-
sign up for ERAS, but not necessarily.
So this actually is just coming from every program site. We have a list of all the programs that were ACGME accredited at the time. We looked at each program site and wrote down the names of all 5 candidates, and then we like internet stalked all 5 candidates to gather
You mean
this
like from my
information.
website?
Yes.
Does not include the unmatched people.
Yeah, it does not include the
Yeah,
unmatched
because the
candidates.
numbers didn't add up for the numbers.
Yeah, I mentioned the limitations. That'd be nice if we could account for those because, with our regression, it's a binary outcome of whether you matched into a top program or just matched in general. But what would be really interesting if we could account for unmatched candidates, because then we could use a statistical test to calculate matching versus
it'd be
not
nice
matching.
to know if all those unmatched people didn't have your internet sites or VSIG, sorry.
Yeah, I doubt they would be
VSIGs.
posting that on their LinkedIn. Like, it's not, like, available.
Because there are a lot of national VSIG things going on now. The covers and VESS especially work together to do that. And I just hope that maybe in the future those things can, if this is one of the key drivers, then hopefully that, I think if nothing else, what I saw in your numbers are if you're at a good medical school that has a vascular surgery program, you're more likely to match into vascular surgery. And we got to figure out how to get the other folks who don't have that luxury built up.
Just make sure you update your website there, Ben.
You're spot on.
Dr. Jordan, of course.
Yeah, I'd love to add to that, particularly the last comment. Will Jordan, Medical College of Georgia, been at 3 different locations, and it's not unlike what Dr. Pierce was saying, sort of the difference between the haves and the have-nots. And so, more importantly, I would first confess that I don't yet know how to identify a good vascular surgeon when they're in medical school. So how can we essentially spread the wealth so people who are at the have-nots, the lower tiered schools, might be able to get into a vascular training program? And ultimately, this one more question on that. I know we talk about matching, and it's something that I've had conversations with Dr. Shahan about. It's not so critical about if we match them. I want you to be more longitudinal and tell me how many finish. Is our attrition rate too high, and can we get people to the finish line? Not just match on the first date, but can we get them all the way across? Thank you very much for the presentation.
Yeah. I think that's a very valid comment. Obviously, we're limited in like the current time, and we can only see the 5 candidates who are currently candidates. And so then we would have to probably check in like after their training and see if they eventually, become an attending or become like full vascular surgeons at an institution. So that would be, I guess, the response to that.
Well, she doesn't have the attrition data, and nobody does. And the reason nobody does is because our attrition rate is so low that the ACGME considers it identifiable to give us any information, because we've already queried for it. So our attrition rate is astronomically low, such that it can't even be published, because to publish it would identify the programs of the individuals who actually quit.
But usually it's within lower than 1% in vascular surgery, which is exceptional. One of the questions I want to ask is, obviously you're coding these schools, your residencies based on the same as the medical schools, the same, grading system. How many people that was in a tier 1 school just happen to go back to their own school which happens a lot, right? You know, especially during the pandemic, you couldn't do sub-Is, stuff like that. Were you able to kind of tease out how much of that proportion?
Yeah, so actually, in terms of like writing the manuscript, that's something we were considering. That was something that was brought up in the discussion process while we were writing it. And so in our like master data table that we have, we still have it like kind of coded to the individual, where they went to med school, and where they ended up matching. And so I think we could definitely account for that if we just rerun the stats a little bit, and we are planning on trying to consider that for our manuscript.
Perfect.
Yeah.
All right. All right, excellent.
Thank
for
you.
your- All right. Oh, sorry. We have another collaborative paper here. We're going to ask Dr. Christine Kwu to come up. The title of the talk is Suicide Ideation Among Vascular Surgery Trainees. Oh, there it is.
Good morning, everybody. Thank you for the opportunity to present on what I think is a very critical topic within medicine overall. These are our financial disclosures. Unfortunately, the rate of physician suicide throughout the United States has increased within the past decade. The last survey from the SVS Wellness Task Force estimates that about 8% of practicing vascular surgeons endorse suicidal ideation, and this rate is probably higher with COVID, some of the workforce issues that our specialty has been experiencing, et cetera, et cetera. So the purpose of our goal was twofold. The first was to provide an updated and longitudinal analysis of rates of suicidal ideation among vascular surgery trainees. And then the second was to hopefully identify some modifiable risk factors that we could potentially intervene on. To answer these questions, we utilized data from the post-VSITE survey as part of the second trial. We asked all trainees, and for those trainees who are in the audience today, you may have remembered this question. We asked everybody during the past 12 months, have you had thoughts of taking your own life? And then subsequently provided the suicide hotline number after the question. To answer the first research question, we performed a longitudinal analysis from the 2020 academic year to the 2024 academic year, looking at rates of suicidal ideation using generalized estimating equations. And then we performed descriptive statistics with both demographic and learning environment variables. So we had over 2,000 responses during the 5-year study period, which came from over 1,700 unique trainees. These numbers correspond to about a 61 to 82% response rate, depending on the year of the study that you were looking at. This chart illustrates the rates of suicidal ideation over our study period. As you can see, the peak was in 2020 at 4.1%, and then the trough was in 2022 at 1.1%. And we found that this rate did not change significantly over the 5-year study period. Now, our response rate was highest in the 2021 data set, so we elected to perform our descriptive statistics on this year's responses. And as you can see, in 2021, 4% of vascular trainees reported suicidal ideation. We actually found no statistically significant difference in demographic factors between the group of trainees who endorsed suicidal ideation and those who did not, but we did identify a couple of significant learning environment factors. These included trainee belongingness, blame within the learning environment, and program responsiveness. As you can see, 3% of trainees who experienced the positive aspect of these variables reported suicidal ideation. In comparison, those trainees who felt like they did not belong amongst their co-residents, who struggled within their learning environment with blame, or who felt that their programs were not responsive, reported much higher rates. We also found that trainees who reported sexual harassment were much more likely to report suicidal ideation. In conclusion, this was a cross-sectional study of suicidal ideation among vascular surgery trainees from 2020 to 2024. There was no statistically significant difference in the rates that we saw during this study time period. We did find a couple of potentially modifiable risk factors, many of which really focus on the relationship that trainees develop amongst themselves and within their program. I will say our study is probably for a good thing, limited by a low event rate, which really precludes our ability to conduct a robust multivariable analysis. And so that may be why we don't see some of the demographic findings that the SVS Wellness Task Force and some other trainee-based studies have found in the past. This does lead me to some of my next steps. I think the first really is to understand how risk profiles may evolve from training into attendinghood. And then secondly, trying to investigate how we can better foster these relationships, not just between the program and the trainee, but also amongst trainees. These sort of relationships obviously are protective for things like suicidal ideation, but have also demonstrated positive effects for other critical things like skills acquisition and standardized exam scores. I think the last thing I wanted to say as I conclude my time is this was obviously an academic presentation, but I do want to acknowledge that many of us probably have experienced colleagues or friends who have lost their lives to suicide, and hopefully by starting this conversation early on, we can potentially identify some intervenable factors that can prevent these challenges later on in the future. Thank you all for your time.
Dr. Chair is going up to the microphone. We'll wait for him.
Thank you, Christina, and all the co-authors for bringing this to everyone's attention. So when I was a program director, I would get the reports from the study, and there were signals. I can't remember the percentages, but they were below the sort of threshold for alarm. But I didn't know what to do with that because it never materialized into anything I had seen from the residents. So what do you do with this information? Because it was difficult to make it actionable, to get to the bottom of it on the program level.
That's a really good question. I think the reason why you probably don't remember percentages is we actually didn't report percentages within all of our studies or within the reports that programs get with the goal of protecting confidentiality. So everything was kind of reported as, are you above average compared to programs of your size, at average or below average? I think the second question that you asked is kind of the million-dollar question, is like, what do we do with this sort of information? If you see that you do have a signal in this area for your program, are there things that you can do to build this and identify the reasons why that is and potentially improve upon it. There are a couple of different interventions within the Second Trial Toolkit that have been designed to help address some of these issues around trainee camaraderie. And there are also other national programs that have been developed in other specialties like near-peer coaching that have demonstrated really strong effects in terms of building that sort of community and the relationships that trainees really need. That's not something that we currently have, but it's something that definitely we're looking into. So I think that's a really good question, is how do we take this information and make it actionable long term?
Like, I just wonder whether the answer was made, in a moment when the trainee wasn't feeling well at that time, and that whether, this is what it was versus a trend that relates to the program and their day-to-day life. It's just very difficult for me to interpret it and to act on it.
So obviously 1% is 1% too high. Are you able to tell us a little bit, I know this is maybe unique to vascular surgery, what is the number for other surgical trainees or just medical, just graduate medical education? Because obviously being a trainee, no matter what field you are, is difficult. Is this something that's unique in vascular surgery and we have to find a solution for that? Or is it just there's something wrong with GME? This is probably both, but.
Yeah, so it's definitely not something that's unique to just vascular surgery. And looking at the general surgery data, our numbers are roughly comparable. There was a recent study, by recent I mean like 5-10 years ago, published by ACGME that did a deep dive not just into suicidal ideation, but rates of all deaths among GME trainees, and that included death due to cancer, death due to suicide. And our rates are a little bit lower than that. Obviously, it's hard to compare study to study if you don't have the actual data, but I would say that this is definitely not something that's unique to vascular surgery.
I think the most concerning thing to me is the piece of the sexual harassment. I think there's really no role for that, anywhere in our work environment. How did this was defined? Like, what are I don't know how the question reads, but what do you guys define as sexual harassment? Because I think that's a very concerning figure.
Yeah, this was actually something that our group a couple years ago did a deeper dive into, but we did define it by not just the action, but also by the individual. So did the trainee feel like the sexual harassment came from an attending, from patients' family? And it's sometimes not the attendings. In fact, if I remember correctly, I think the percentage is about roughly equal between from faculty members versus from patients and patient family members. I think that's obviously much harder to address when you have patients who may be making offensive comments or unneeded advances. So that's definitely another area that probably needs an updated analysis and look at as well.
Okay, great. Thank you. A very important work. We're looking forward to hearing your next steps in the subsequent meetings. So thank you.
Okay, the next paper will be presented by Dr. Park, Operative Confidence of Graduating Vascular Surgery Trainees.
All right. Thank you so much for the opportunity to present. So vascular surgery training over recent decades has undergone a major change. The emergence of minimally invasive techniques have shifted the management of various pathologies and has had significant effect on training for both fellows and integrated residents. For instance, the adoption of EVARs have substantially reduced the number of open aortic aneurysm repairs, and this has influenced the training experience as fellows. As shown here, has had a decrease in overall open aortic experience driven by fewer repairs for aneurysms, despite the increase in repair for AIOD. Correlatively, a study by O'Leary et al. In 2012 showed that trainees graduating from pre-2000 had a higher comfort level with open AAA repair compared to those with graduating post-2000. And this has brought up concerns regarding the competence of modern graduates to independently perform these cases. Outside of open aortic procedures from some of our own previous work looking at the ACGME case logs, we've seen a decrease in carotid endarterectomies with a concomitant increase in carotid stent placement since the FDA approval of TCAR in 2015. And we've also seen a decrease in EVARs and open visceral bypass among vascular fellows since 2008. So with all this in mind, our objectives were threefold. We wanted to assess the current training experience from the most recent graduates and their ability to perform in various core open and endovascular procedures. We use confidence levels as a surrogate marker for operative competence and assess factors that include demographic, training program characteristics that could affect confidence levels in performing these procedures independently. Additionally, we wanted to explore areas that trainees did not feel as well prepared for, and if there was any desire to pursue additional training to supplement this. A 14-question anonymous survey was distributed. We queried respondents regarding demographic and training program characteristics, total number of open abdominal cerebrovascular, peripheral, and endovascular cases they graduated with. They then rated their confidence levels in performing select procedures on a Likert scale from 1 to 5, with 1 defined as non-confident and 5 defined as practice-ready. A total of 22 procedures were selected that ranged from essential core open procedures to more uncommon and complex procedures, both open and endovascular. We received a total of 67 respondents from our survey. The mean age respondents was 36.4, with the majority being male fellowship graduates, graduated in 2024 from a university program from the Northeast and had greater than 8 attendings in their training program. Among the 22 procedures, graduates have demonstrated confidence in most procedures. However, 80% or less have reported to be confident in performing open elective and ruptured AAA repair and visceral bypass, and around 50% or fewer for TF-CAS, thoracic outlet decompression, and open thoracoabdominal aortic aneurysm repairs. We identified certain characteristics correlated with operative confidence in certain procedures. However, we found these factors to be clinically less significant, as the confidence levels range from 4.5 to 5 between the two comparative groups in their respective category. But in contrast, surgical volume, particularly in open abdominal cases, correlated with significant improvement in operative confidence. Graduates with more than 45 open abdominal cases demonstrated improved confidence in open repair of ruptured and elective AAA aortobiphent bypass compared to those with 30 to 45. Graduating with greater than 60 improved confidence repair of thoracoabdominal aortic aneurysm, visceral bypass, and mesenteric embolectomy. We then compared confidence levels in performing endovascular cases to their open case counterparts, and predictably, we identified a higher operative confidence in endovascular procedures. And in our multivariate analysis, we found that increased surgical volume was an independent predictor for improved confidence levels in open elective and ruptured AAA repair, aortobiphent bypass, and open thoracoabdominal aortic aneurysm repair. Lastly, 42 out of 67 of the respondents had answered our open-ended questions in the survey. The most common aspect of vascular surgery that trainees did not feel prepared to deal with independently was open repair of thoracoabdominal aortic aneurysm followed by open AAA repair. And 2 out of 67 graduate trainees had the desire to pursue additional training to better prepare themselves. In conclusion, our results demonstrate that overall, our most recent vascular surgery graduate trainees are graduating with confidence in most core open and endovascular procedures. Predictably, this is higher in endovascular interventions compared to their open counterparts. There are some procedures, however, particularly open aortic procedures that more graduates reported as not confident to perform, and this was also echoed in our open-ended survey questions. Some efforts to improve confidence include aortic or transition to fellowship programs. However, our survey shows that this is not a popular choice. Alternatives may include high-fidelity, validated simulation, or potentially an option for dedicated months to outside elective rotations during training to those who are interested. And lastly, graduates with a lower volume should consider early career apprenticeship where they can go to a place with senior mentorship with higher volumes to improve confidence and avoid stunting their development. All right, thank you so much for listening.
Dr. Chair's coming up the mic over there.
Thank you for this work. How do you think the perception of confidence correlates with practice readiness? Because those are two different things. Someone may be practice ready but not confident, and that may be affected by so many things, whether it's their personal perception. Studies have shown that gender can also impact how you perceive your readiness, but at the same time, someone may be confident but really not practice ready. So what do you do with this? Are you going to recommend all these things at the end based on that perception?
So that is a great point. It is conflicting. There are conflicting papers on whether confidence necessarily correlates with competence, but there are proponent papers that support it. And you're correct, sir. So like females or younger people generally perceive themselves as having lower confidence in their actual competence levels, but that is a limitation we have. But we do think that there is support from both general surgery as well as other surgical specialties where they can assess their competence levels that somewhat correlate with their competency.
I wonder if you have the opportunity to go back to their program directors, those who responded, to get that objective assessment and see how they match, maybe.
No, that's a great point too. The general surgery papers, some of them also have done a survey where they asked the program directors in response to asking the trainees themselves. And that is something that we should definitely consider.
I mean, I think when every graduate, what gets signed off by their program director with an attestation that they're practice ready. So I think, that's going to be 100%, right? Otherwise you don't graduate. Dr. Escobar, it's a question, and then Dr. Rowe.
Just a quick comment. A lot of times we talk about this concept about, are we confident with open aortic and are we confident with all these different procedures? I would highlight that probably in this room, if we raised our hands and say who's competent or who feels comfortable doing a thoracoabdominal or even thoracic outlet syndrome, not all of us need to be comfortable and confident in those particular fields. And as I say this, there's different programs that have a lot of skill in certain things and you just don't get exposed to everything. But that doesn't mean that you can't be a vascular surgeon. You simply have to graduate knowing those restrictions are there. Or pick a practice where you're going to become paired up with somebody who is an expert and subsequently build that up. So I don't think we necessarily need to focus too much on this, although certainly when we finish, if we want to train more people to be competent with open, et cetera, then all of us in this room need to decrease the number of EVARs that we do and start doing more open. Because if we don't, we can't expect the trainees to know how to do it either.
Right, yes, another great point. Thank you so much, sir. So I guess a subsequent study that we can do is we sort of ask the same respondents, essentially how many of you guys are doing these procedures, because if they're not, then you're correct. Like the results that we find may not necessarily, it might be more of a moot point since they weren't doing these procedures anyways. So whether their confidence levels are, high or low may not be as important of a point.
Okay, we got 3 more questions. Dr. Rowe, Dr. Scory, and then Dr. Jordan.
Yeah, mine's just a generalized comment, not to you. You did a great job with your research and your presentation. More to the vascular community. We saw the other day all the people involved, ACGME, APDVS, VSB, SVS, all these people that are involved in making sure that we as a specialty continue to move forward, and also we're training a great product. But I think this whole what's changing in our practice and open AAAs, this, and I think that we just got to put that to rest. I mean, when the ACGME has this number set at an unrealistic number, all the trainees do walk around in practice around now, I don't have enough of this, I don't have enough of, well, you got a lot of this and you saw this. I mean, we really got to put this to rest so that people aren't just pushing, I have to get this open AAA. And I think we can do that, and I think that it will help to change the paradigm for the trainees. The 5 and 2s always come in and ask, well, how many open AAAs, how many open procedures do you do at your center? I said, well, how many open choles did you do during your general surgery training? And it's almost as if they accept the fact that laparoscopic or robotic chole or whatever is the standard, but we still haven't gotten to this acceptance level of the fact that we do EVARs, we do TCARs, and this is just how our practice is. So just a generalized comment, but thank you for your research. It was good.
Thank you, sir.
Mr. Corey?
Yeah, no, thank you so much for your presentation. I really enjoyed it. I would echo off of what Dr. Scher said about not only being practice ready, but the reality is that us as program directors or as faculty members, we need to help our trainees in their job search and making sure that they are choosing senior faculty members or senior partners that are going to help them, because no matter how many open aortic ruptures you've done in your training, you're still going to be nervous the first time you do it as an attending, and you're going to want a second hand. So I think we should all be assisting in that practice. The other thing is, it's amazing how many individuals could go on a back table and set the fenestrations for a PMEG, but then don't know how to do a proper below-knee amputation and a posterior flap, or don't know how to do an AV fistula, which is the more common things they're going to do in their practice. So our focus constantly is on these open aortic cases, but the reality is that we have a lot of people that aren't practice ready for standard vascular care, and I think as a society we have to pay attention to that.
Yes, so that was part of our, the objective of our study was that a lot of focus was already around, and the studies have been around aortic training, but we saw, as I've quickly mentioned during the background, that we've seen decreases in carotid endarterectomies due to the concomitant increase with stents. We've seen decreases in EVARs as well as open visceral bypass and some other stuff that we found. So we wanted to see, wanted to have an overall assessment of if they're still being, properly trained, and obviously we're using. Another limitation is that we're using confidence as a competency level as a surrogate marker, so there is some limitation with that, but that is essentially what we tried to do with this study.
I'll be quick, thank you. I think it's a great conversation about confidence or comfort, and you feel comfortable. I mean, I still don't feel comfortable doing a thoracoabdominal, and it's okay to have a little anxiety when you're doing a big, tough operation like that, right? And so I guess, the real warning is I think we need to be careful using volume as a true assessment of your training, and we ought to do a better job of skills assessment, and what can they do? One other comment, I think it was Rabih's comment about how you assess one and whether the program director gets to sign off and attest that, yes, they're ready for practice. And there are a lot of implications in that, Dr. Jim, because if you don't sign off, you're basically concerned you're going to get legal action against you. So there's a lot of concerns. But I think one tool that we've used that's been helpful is have the trainee do their self-assessment. I think it's incorporated in the EPAs. I'm not quite familiar, but they do a self-assessment first, and then you get to critique after that. And I've found as I go through that, some people are really hypercritical, and they think they're not doing well, and they are, and others are like, hey, I got this, and you're like, whoa, you could barely close, And so I think self-assessment and then immediate reflection is a good tool to help solve some of this. Thank you.
Perfect.
Thank you.
All right, thank you very much. We have our next speaker come up, Dr. Julia Kessel from University of North Carolina. The title of the talk is Vascular Surgery Residency Matching, Impact of Completion of a Visiting Student Rotation Increase on Matching.
Good morning and hello. My name is Julia Kessel and I'm a current UNC School of Medicine student. And as mentioned, our project title is Vascular Surgery Residency Matching, Impact of Completion of a Visiting Student Rotation, Increase on Matching. And our team has nothing to disclose. So the goal of our project was to analyze if the completion of a visiting student rotation, also called away rotation, correlated with successfully matching. Secondarily, we aim to evaluate the impact of applicant characteristics like STEP scores and honors clerkship grades, as well as the COVID-19 pandemic impact on matching into vascular surgery. We use self-reported data from vascular surgery applicants from the Texas STAR database from 2017 to 2023, and all vascular surgery applicants who completed at least part of the survey were included, and an example of the Texas STAR homepage can be seen on this slide. Overall, we analyzed 123 vascular surgery candidates over 6 years. Over this time, we noted an increase in the number of residency positions, applicants, programs applied to, interview offers, and interviews attended. When comparing matched versus unmatched candidates, matched applicants attended significantly more interviews compared to their unmatched counterparts. And interestingly, unmatched applicants had significantly more research activities on average, but there was no significant difference in other applicant characteristics like STEP scores, volunteer leadership experience, surgery honors, dual degree, or having a research year, though we think this may be a limit to our analysis based on our sample size. Over half of the applicants we looked at completed at least one away rotation, and respondents who completed at least one away rotation had a 1.8 times unadjusted odds of matching compared to respondents who did not complete an away rotation. Participants who completed at least one away rotation were also more likely to do so during non-pandemic cycles. And those who completed at least one away rotation applied to an average of 2.1 more programs, received 4 more interview offers, and attended 0.4 more interviews than those who did not complete away rotations. Of the matched applicants, 18% completed an away rotation at the institution where they matched. And interestingly, there was no statistically significant difference in the number of publications, total research activities, or leadership experiences between applicants who did and did not complete away rotations. However, applicants who chose not to complete an away rotation had slightly more volunteer experiences, publication, and leadership experience. The COVID-19 pandemic impacted applicants' decisions to complete an away rotation, conduct a year of research, and the average cost of the application season. The number of applicants who completed a research year was significantly higher during the pandemic compared to non-pandemic years. Additionally, there was a significant difference in the total cost of applicants and interviews during the pandemic cycles compared to non-pandemic years. So overall, our findings suggest that while interest in vascular surgery residency is growing, the path to successfully matching remains unclear. Away rotations do increase the likelihood of receiving an interview invitation, but they do not significantly affect matching at the away rotation location. Similarly, factors like board scores and clerkship grades did not show a significant impact on matching, but this was probably likely due to our sample size. And the role of personal statements and letters of recommendation, as well as other qualitative factors, still remain unclear. While the matching process is complex, our results from the Texas STAR database provide useful insights for applicants considering away rotations. And our study emphasizes the need for further research and the release of applicant data to help future candidates make a more informed decision on if they choose to do away rotations and where they choose to apply. Thank you so much for your time, and I can take any questions.
Dr. Pierce.
Thank you very much. That was really well presented, and we look forward to you doing an away rotation in a few years. I'm not quite as, I've seen this STAR thing before. Does this incorporate DO students too, or is this just MD applicants? You may have put that up there, but I missed it.
No, great question. So the Texas STAR database is self-reported. So when applicants apply to residency, they get an email from the Texas STAR upon, a few months of graduation. So it includes all international medical graduate, MD students, as well as DO students, basically anybody that applies to a U.S. residency position. And then, of course, it depends on who fills it out, right? So since it's optional and self-reported, it's not required to be filled filled out. So we noticed in our study that most of the people that filled it out were MD students. And also the bias of filling it out based on if you match or don't match. I can imagine if I did not match, I would be very upset and probably wouldn't fill this out. So I think a large majority of the applicants that filled out this were people that matched and also happened to be MD students.
And thank you for the background. That's very helpful. I mean, this is probably one of the strongest ways that people can currently signal. We talk, I know that that's a whole other topic, but I mean, having somebody come to your institution is probably very meaningful. And I just would be curious, I was just asking Misty, but if anybody has a rigorous way they actually evaluate people that apply to your program, I usually just look at, it's me, I look at their CV and I say yay or nay, and it seems pretty arbitrary actually. So maybe there's a better way to do the evaluations of the people that want to come visit.
Yeah, and I think I want you to comment a little bit as we get away with number of board scores and app sites are going away, pass fail. Like you mentioned, I don't think that this is going to be an option. People are going to see this data, which is what confirms what all of us thought. How are we going to deal with that? For one of the issues about virtual interviews is disparities. You don't have to fly everywhere, but now you not only have to fly somewhere, you're going to have to live there for a month and actually show off and get the letter. So Dr. Pierce will take me in his residency. Any comments on what will happen with that?
Yeah, absolutely. I am a huge advocate for visiting student rotations. I think they're incredibly helpful. Like you said, it's where you're going to land for the next 5, 7, 10 years. It's also the people that you're going to work with, and you're going to spend, 80 plus hours with them. So I think it makes a big difference. I think one of the things that we found was really interesting was only 18% of the people that completed visiting student rotations actually matched at those institutions. So I think visiting student rotations are sort of a double-edged sword. Whether you get the yay or nay on your application or not, you could go, live there for a month and then not do a good job, and that program may not want you. So I think it's, for applicants to weigh the cost benefit analysis, they also have to look and be very honest with their mentors about their clinical performance too, because they may have a strong application and a poor ability to demonstrate their clinical knowledge.
I found that some schools have a variable amount of away rotations that they allow, and that sort of sets them up for problems. The students can't go to all the places they want to, or they are limited. They may only have one away rotation. On the other hand, you're looking at it from the point of view of the program, and I find that some away rotations, students go on, they're disappointed, and they find that this is not the program for me. So if you could just comment on both of those issues, because I think as you said, it is a double-edged sword, but it's setting up a have and have not situation between some schools.
Yeah, I think like some of the other presentation mentioned, like the role of interest groups. And I think in terms of limiting the number of away rotations based on the institution, like based on the med school, I think that's really where your mentors come into play. Like having a vascular surgery interest group or a mentor that really advocates for you and can advocate to the higher ups of your med school that, hey, we have this good data that says that you need to do an away rotation or maybe 2 or 3 based on your application. I think that's really where mentors would come in to advocate for you in that role. I think unfortunately as a student, your hands are sort of tied by a lot of that red tape. And then the second part of your question, sorry, could you remind me what it was?
Sometimes the students go on a rotation and they find, this is not for me.
Yes. I think, like we mentioned, the double-edged sword of away rotations, I think, med students, we get a really wide breadth of training as third-year students, but we're also shielded from a lot of things. Like, I love being a med student. I love, writing notes and things like that. But at the end of the day, I'm not personally responsible for the billing and the coding and like some of the other things that my residents do. So I think as med students, we're shielded from a lot of what our life could look like as a resident or even attending physician. So I think sometimes it may be an institutional bias where you love the people at your home institution and then you go somewhere else and it's not what you expected, or you go somewhere else and it's better than you expected, or it's just somehow different, or maybe you don't like the area or your family's not there. So I think there's a lot that can go into it. And I also think a big piece that's missing from this database is qualitative things, right? So who wrote your letters of recommendation, what's in your personal statement, and how do you evolve as a student on a 2-week vascular elective versus a whole month at a different institution, and how maybe, 6 weeks on it versus 2 weeks could change your opinion of the specialty in general or the people that you're working with. But I think it's tough. It's very tough.
One more comment from the back.
I was just going to say, I think this Texas Star is an excellent tool to be able to use. But we did the study at Stanford also in the pre-COVID era, and we had over 80% of surveys replied to through the APDVS Research Committee. Over 50% matched either at their home institution or where they did a sub-I. So it is obviously a huge factor that still plays a role going to a sub-I.
Yeah, absolutely. Thank you for that.
Thank you. All right. The next will be another collaborative paper presented by Dr. O'Reilly from Northwestern, Current State of Interventions to Assist Trainee Parenthood.
Thank you for the opportunity to present our work. We have no disclosures. So surgical trainees who are parents may encounter unique struggles in achieving work-life integration. Vascular trainees in particular may be susceptible to these challenges, due in part to small trainee program size with limited redundancy, long cases with complex pathology, and frequent emergency surgeries. Several studies have recently published assessments and interventions to assist trainee parenthood, including some specific to vascular surgery. However, the use of these interventions and program support for trainee parenthood is not well understood. Therefore, the objectives of our work were to evaluate rates of trainee parenthood in vascular surgery. We sought to understand the current culture of parenthood interventions used by training programs and explore the relationships of these interventions with program support. This was a cross-sectional study of vascular surgery trainees who participate in a survey as part of the vascular arm of the second trial. Trainees who are on academic development time or without data on the outcomes of interest were excluded. We asked trainees a series of questions about trainee parenthood and their program support, and the responses are measured on a 5-point Likert scale, which we dichotomize into positive or negative responses. Trainees are also shown a list of parenthood interventions and asked which have been used at their program. Our primary outcome was perception of program support, and our secondary outcome was interventions implemented by programs. We had a 65.7% response rate for the questions of interest. Overall, there was 135 vascular trainees who were either currently parents or expecting parents. We found that trainees who were male were more likely to be, or trainees who were parents were more likely to be male. They were more likely to be in advanced PGY years and more likely to be married or in a relationship. And there was no significant associations with race, ethnicity, or program geographic region. Overall, trainees felt supported by their programs, and 88.6% felt there was formal and adequate measures to support parenthood. Most trainees felt there had been interventions implemented within the past year to assist with parenthood. And overall, when dichotomizing the responses, 87.5% of trainees agreed with all the statements of program support. The most utilized interventions by programs were appropriate lead, and including maternal lead, and then flexible parental leave policy, allowing for at least 6 weeks based on ACGME policies. The least utilized interventions were a transition period after parental leave and subsidized childcare. On bivariable analysis of the demographics of programs on bivariable analysis of demographics and program support, we found that women with and without children were less likely to feel supported to pursue parenthood than men with and without children. And there's no significant associations with race, PGY level, relationship status, or geographic region. On our bivariable analysis of interventions and program support, we found that all of these interventions listed were associated with feeling that your program supports your pursuit of parenthood. On a multivariable logistic regression, having a backup call schedule was independently associated with feeling supported by one's program to pursue parenthood. However, female gender remained independently associated with feeling unsupported. Our survey is limited by recall and selection bias, and specifically trainees may not know of interventions unless they themselves have used them or someone in their program has used them. We also excluded trainees who are on academic development time, which may be a time that trainees are thinking specifically about these issues. However, this reflects a very small proportion of trainees in the US. It's also likely that the effects of interventions are not likely seen immediately, as this kind of reflects a culture change in many programs. And parental discrimination or lack of support may not come from a program specifically, but may come from outside sources. So it's important for programs to have visible support of trainee parenthood. And finally, pursuing parenthood is obviously a highly personal decision that might not be desired by all trainees. But we advocate for the fact that if there's interventions for trainees to support their parenthood, those interventions will likely benefit all trainees, regardless of if they have children or not. So in conclusion, most trainees feel supported by their program to pursue parenthood. Backup call schedules were significantly associated with feeling supported. And while balancing parenthood and surgery is not exclusive to female surgeons, there are inherent differences in challenges that are encountered, which is reflected by the significance of gender in our multivariable assessment. And finally, we must continue to push forward with interventions and culture change to facilitate support for people pursuing parenthood, as recruitment and retention of a diverse workforce is inherently linked to the ability to support parenthood for trainees. Thank you, and I'm happy to take any questions.
Do you know if, I didn't see the questions you guys asked, I missed that, but was there any questions about infertility treatment or support for that? Because that's becoming a big issue in today's society.
Yeah, that's a great question. We didn't include any of those on this survey, but I think in future iterations of the survey, I think that's something to investigate, especially because a lot of programs are offering support and subsidizing that sort of treatment. So I think that's a future direction for us.
Do you notice with a lot of training programs across the country moving to unionization, and one of the things that they talk about is childcare and potentially, support during parenthood. Do you think that's going to be something that's going to affect how this is going to be going forward, as most training programs are going through that route?
Yeah, I think that's a great point. I don't have the data on that specifically because I think unionization is a relatively newer concept for a lot of programs, but anecdotally, I do think that training or programs that are pursuing unionization are more likely to include infertility benefits in their contracts. And so I do think that we'll see a lot more accessibility of that for trainees in the future.
And then you said there were more male who were parents, but were they parents before they started the program, or they became parents while in training?
Yeah, that's a great question. We can't discern that with the questions that we ask. We're limited by the time that people are taking the survey and the number of questions we're able to ask. So we weren't able to determine that, unfortunately.
Oh, comment back there.
Kelly Kemp from University of Oklahoma. Thank you for your work. So, in addition to what you stated to help trainees feel more supported, on a program level, what else can we do now to give that support? And then from a society level, what can we do?
Yeah, thank you for that question, Dr. Kemp. I think this is a really important part of this work, and I think one of the biggest things is having very visible and performative program support of trainee parenthood. I think a lot of times when people are encountering discrimination or harassment, it's often not coming from the program itself, not coming from necessarily the faculty that trainees are working with every day or even their co-residents. I think it can come from a lot of sources outside of the program, but within the hospital system. And so I think making sure that there's kind of a zero tolerance policy for any sort of discrimination, regardless of if it's trainee parenthood or sexual harassment or anything like that, I think that goes a long way. There's also some guidelines that have been recently published in 2024 about ways to support vascular trainees specifically for parenthood, and I think taking a close look at that and just making sure that a lot of the basics are covered. Do your trainees have maternal lead? Are you protecting the mother and the fetus both? I think those are great places to start, but I do think that further investigation and ultimately qualitative investigation of this will be the most revealing.
Appreciate it. Thank you.
And I would say, I think Dr. Coleman, who obviously leads APDVS, is working on some guidelines from the program director group for all the programs as well. Last question, comment.
Just to answer that, one of the things that I found most helpful is that at your welcome to my program moment, whatever it is in June or July or whatever, that you specifically state at the get-go that you have a policy supporting this. And the other way to do this is that you incorporate it into unforeseen family and or illness to say, if for whatever reason you need X amount of time off, or if for whatever reason you can't take call because you threw out your back, or if for whatever reason that your program already does it. I got surprised with 2 trainees simultaneously pregnant with similar due dates, which obviously made call schedule and et cetera, very challenging. And after that, when we incorporated it, and then when it happened again, I had 2 trainees simultaneously pregnant around the same due date. It was fine. Everybody worked together and it wasn't a big deal. So establish it as part of your culture at the very beginning, and then it's not this whole scramble and whatever, stereotype.
That's a great point. Thank you.
Thank you very much. Thank you. We have our next speaker, Dr. Pavan Gaduri, is going to present on predicting general surgery residents' competence and autonomy in core endovascular surgery procedures.
Good morning, everyone, and thank you for the opportunity to present our work. We have no relevant disclosures. So, for a little background, vascular surgery remains a core component of general surgery training with 50 required minimum cases in vascular surgery for graduation according to the ACGME. Core vascular surgery education is important during general surgery training to both recruit fellows and train well-rounded surgeons able to practice in a range of environments. As vascular surgery becomes increasingly endovascular focused, the extent of endovascular exposures general surgery residents receive is unknown. With a projected shortage of vascular surgeons and a projected increase in the proportion of endovascular procedures, endovascular exposure is necessary for a holistic appreciation of vascular surgery. So the aim of our study was to investigate the competence and autonomy of general surgery residents performing core endovascular procedures. For our methods, we did a retrospective analysis of simple evaluations completed by faculty across the country between 2015 and 2024. And these were assessments on categorical general surgery residents across 65 programs. So we divided endovascular procedures into 5 major categories: AV access, cerebrovascular, endoaortic, PVI of the lower extremity, and endovenous. And we used generalized linear mixed models to predict competence and autonomy in performing these procedures. So this was the distribution of competence and autonomy. For a given endovascular procedure, exceptional and practice-ready performance were used to indicate competence. And for a given endovascular procedure, passive help and supervision only were used to indicate meaningful autonomy. And we found that the predicted probability of achieving competence was highest for AV access and endovenous procedures across cases of various levels of complexity. Again, we saw that the predicted probability of achieving meaningful autonomy was highest for AV access and endovenous procedures across cases of various levels of complexity. So overall, we saw that AV access and endovenous cases had the greatest predicted competency and autonomy, while cerebrovascular and endoaortic cases had the lowest predicted competence and autonomy across cases of various levels of complexity. So why does this matter? Implications include increased fellowship recruitment of general surgery residents, informing future general surgery educational curriculum changes, and increased ability for general surgeons to work across a range of practice models. Thank you.
While Dr. Kemp gets on the mic, you know, one of the things that you mentioned, have you been able to track looking at these individuals and how many of them actually went to vascular surgery fellowship? I don't know if that's something you can ascertain from websites or whatever.
Yeah, no, I think that's a very interesting question. And no, we did not look at, which of these residents end up pursuing fellowship training and what they end up going into. And I think that'd be a very useful next step to see, what their degree of endovascular exposure has to do with the fellowship that they pursue.
Dr. Kemp and then Dr. Lumpson.
So I appreciate your study. I'm very passionate about this. So one of my first clarifying questions is, did you look at the year of training? And forgive me if I missed that.
Yes, we did. We looked at PGY 1 through 5, and we saw that the competency and autonomy, both progressed as their training year progressed, which is what we expected.
Were the majority in the lower years? So one of the challenges, I think, is as we're recruiting, a lot of us have general surgery residents that are only lower levels, and that we lose them after their first and second year. So that's why I'm asking specifically.
Yeah, the assessments were pretty evenly distributed across PGY 1 through 5.
Thank you.
Dr. Lumsden.
Yeah, I mean, congratulations on at least bringing this problem up. Video equals data. It used to be video was something you showed how to do this. That has moved. Everybody wants video from an operating room for the cases because all the companies understand that they can use computation, the cameras to actually track motion. And so Intuitive, of course, have done this par excellence. You can't get a robotic certificate, but you now have to agree to let them get all the data. So they know who's good, they know who's bad, they know who's the efficient surgeon. And I think we got to learn from that. I mean, they've got their own app that everything gets tracked into. And the question is, you're looking at the general surgery world. That's the world these people are living in. Are there lessons that we can take from that to define who is a competent surgeon? The problem with videos, it takes forever to look at it, and nobody's going to do that. It's going to have to be some way that's going to be automated, and are there lessons from that that we can learn here?
Yeah, to translate that to the endovascular space would be, I think it would be interesting and a little bit challenging because it's not, it's not as intuitive. The steps are not as clearly defined, and there's a lot of different variation in any endovascular procedure. So I think that's definitely something that would be challenging to incorporate, but also something meaningful to attempt.
One more comment, Dr. Harris.
Were you able to correlate at all whether or not the individuals who scored higher or lower had competing vascular integrated or fellowship programs in their institution, and or did they have sites where the vascular trainees did not go? Because that would be something of interest if there's a difference between programs that have competition and those that don't. Thanks.
Yeah, I think that's actually a very important thing that we want to look at when we write our manuscript, and to see if there was a difference in programs that had competing integrated and vascularship programs.
Great.
Thank you.
Good job.
Thank you.
Another collaborative paper, Love's Labor Loss, exploring the premium associated with academic practice in cardiovascular interventional subspecialties. This will be presented by Dr. Parkish, who's working with our president, Dr. Bismuth, at the University of South Florida.
Good morning. Thank you so much to the Society for Vascular Surgery, for Clinical Vascular Surgery, for allowing us to present our work today. I'll be presenting our project looking at the financial premium associated with an academic career in cardiovascular interventional subspecialties. These are our group's disclosures. The desire to pursue a career in academic medicine is generally multifaceted and can include providing cutting-edge technology, caring for complex patients, collaborative environments for innovation and research, ability to train and mold the next generation, and various leadership pathways. But with these altruistic desires comes a trade-off, and for academic clinicians, that is compensation. Our previous work has shown that academic surgeons are charged a premium of 16% to work in academia, despite generating higher RVUs and having higher collections per work RVU. In this study, we did not compare individual subspecialties. So this brought us to our study question, which was to determine the difference in value of clinical effort between academic and non-academic cardiovascular interventional subspecialties as normalized to the work relative value unit. We use the MGMA provider compensation data as it is comprehensive, separates academic and non-academic organizations, and was readily available during our study period. We decided to look at cardiovascular interventional subspecialties, namely interventional cardiology, interventional radiology, and vascular surgery. The metrics we collected from the MGMA database include the total cash compensation, work relative value units, reported total cash compensation per work RVU, and then we performed a linear trend analysis on the total cash compensation per work RVU to predict future values. Our results, Work RVUs generated in the academic interventional radiology and vascular surgery subspecialties were noted to be greater than their non-academic counterparts in all years. In comparison, academic interventional cardiology generated less work RVUs than their non-academic counterparts in all years. When we look at total cash compensation, we see that it's increased in all cardiovascular interventional subspecialties, academic and non-academic, during our study period. Compared to non-academic interventionalists, a larger increase in total cash compensation was seen for academic interventionalists in all specialties all years. And regardless of this trend, academic cardiovascular interventionalists made significantly less than their non-academic counterparts in all years, all specialties. When looking at the total cash compensation per work RVU, we see that it's increased in all specialties, academic and non-academic, during our study period. Total cash compensation per work RVU was less for academic subspecialties compared to non-academic, except for interventional cardiology in 2018 and interventional radiology in 2014, where academic and non-academic compensation were equivalent. We then used linear regression to perform a linear trend analysis to evaluate the total cash compensation per work RVU over time by subspecialty. In interventional cardiology, we can see that there's a predicted convergence in 2042. And in 2022, the academic interventional cardiology total cash compensation per work RVU was 14.7% less than their non-academic counterparts. For interventional radiology, the linear trend analysis suggests divergence. And in 2022, academic interventional radiology total cash compensation per work RVU was 12.7% less than their non-academic counterparts. And finally, for vascular surgery, we also see a diverging pattern in the linear trend analysis, and see that the current gap is 12.4% between academic versus non-academic vascular surgeons. In summary, all academic cardiovascular interventional subspecialists receive lower total cash compensation in all years. This is despite the fact that, particularly in interventional radiology and vascular surgery, academic interventionalists generated more work RVUs than their non-academic counterparts. Based on total cash compensation per work RVU, academic cardiovascular interventionalists are charged a passion tax to work in academia, with interventional cardiologists incurring the highest tax at 15%, followed by interventional radiology at 13%, and vascular surgery at 12%. Our limitations, we did not perform a comparison between male and female compensation, which unfortunately still does exist. And the MGMA database is based on survey respondents, and so is variable and differs from year to year. In conclusion, academic cardiovascular interventionalists pay a passion tax compared to their non-academic counterparts, and individuals must decide for themselves the value of pursuing a career in academia and at what cost love labor is lost. Thank you.
I'm sure the audience is all a lot of passion tax payers right now, wiping their tears. Dr. Chair.
Thank you. Well, maybe not thank you. This is a little depressing, but the question is, this is work RVU data. Do you have any data on actual collections and what those differences are? Because this might impact actual compensation as opposed to just work RVUs.
Yes, for this paper, we did not look at the actual collections. In our initial paper, we did look at collections, and the collections per work RVU were higher for the academic providers compared to their non-academic counterparts.
Dr. Jordan, Dr. Lumsden.
I'd love to hear which of the authors chose the term passion tax. I would have called it a dean's tax, so please explain. Thank you.
Yes, this was a controversial topic while we were discussing the title of our presentation. Was more to provoke conversation and emotions, I think, than anything else.
Alan Lumsden, Houston. So it's a good topic, but it's not new news. When I was offered a job when I was in Scotland 35 years ago, I was told, Dr. Warren, the chairman at Emory, will give you a job if you're going to be an academic surgeon. He's sick and tired of training guys who want to be multi-million dollars in private practice. So that was 35 years ago. I was told up front there was a price to pay for being academic. But the challenge I've got at the moment is that, number one, what is an academic surgeon? I mean, you're going to have to define that. We got people in the community who can do a little bit of academics, but not the same as the people downtown. And then the pushback from the hospital is, but you got residents, okay? I come in at night to operate. I don't come in at night to do consults, and I don't come in at night to put in central lines. And so there is a quid pro quo there, and exactly that's worth a lot of money to me, not to be the guy who comes in the middle of the night to put a central line in for somebody. And so it's not all just them taking and not giving. And so there's a resident factor that we have access to. In other words, we have more help sometimes than the people in the community have. How does that play into it?
Yes, and obviously we can't account for that with the MGMA database, but it is a topic that has come up in the discussions of this paper, is when you look at the maybe quality of life as far as advanced practice providers and residents, and the ability to be more clinically productive and produce more work reviews as an academic interventionalist versus a non-academic probably does play into the data that we see.
I want to make a counterpoint, though, to Dr. Lumsden, no offense. Yes, but we're their call team when they go on vacation. We get all their really bad things. Not all of them, but we get a lot of the community practice people's stuff at night, weekends, holidays, things that should also be done by us. But we have residents, but we do a lot of stuff that they don't do. And so I do think that the only way you can really measure it is with money. So if that's the way they're going to do it, I think we need to be compensated. We should stand up and say we should be compensated for all that extra work.
Yeah, and to Dr. Lumsden's point, I do think that the concept of the academic surgeon or the academic physician is changing over time. I think the subsidies from the university and being able to do research are decreasing. I do think that even the academic institutions are now being run by non-clinical people that are very business-oriented, and there is a lot more focus on clinical productivity. And so sometimes we have to also look at that, and I think it'll be interesting to see what this data does over time as those practice models change in the academic setting.
Yeah, congratulations, great work, very important, and thank you for sharing that with us.
Thank you very much.
To bookend this session, we have another disparities talk. Very excited to introduce Dr. Gabriela Velasquez from Wake Forest. Her title of the talk is Leveling the Playing Field, Addressing Disparities in Vascular Surgery Training.
All right. Thank you. Thank you for having me. Good morning, everyone. It's just me and then your coffee break, so some food for thought. So today I'm going to talk about some ways that we can address disparities in vascular surgery training and how we can come about leveling the playing field and what we can do about it potentially. All right, have no particular conflicts for this talk. So we know that disparities exist in vascular surgery training. There's a lot of data, again, we're not going to go do a deep dive into that, but we know that underrepresented minorities in terms of the trainings is an issue. We can also base it in buckets such as implicit bias in assessments, mentoring, procedural exposures, barriers to women, first generation, international medical graduates, and also geographic and resource disparities between programs. So this is kind of, I think we can kind of bucket all of these disparities that can account for disparities in vascular surgery training. We know that even though the minority recruitment has increased, as well as entering the medical student and recruiting them for the vascular surgery task, workforce, we're still not seeing that projection as where they go into their jobs and leadership positions, grant funding, presence in the community, et cetera. So even though we're doing a lot of work to try to recruit these folks, we're still not seeing it in terms of percentages for the last 3 decades almost. Now, there's such a thing of a hidden curriculum and how it excludes some learners. If you can think about, you go through your interview process, you interview fellows and residents, and you see people that are extremely qualified, they come from really good programs, they have really great letters, but then you finally got them, you're looking for these, again, people that look like me, that we're not, people of color, and then they get to us and they're like, then what? Are we doing right for them? That's the question. We're doing all the work to get us to our environment, and then what do we do? Is there such thing as learners are different, not just because of the way your skin looks, but also we have a diversity of background, the way we learn, where we come from, are we first generation or not, what kind of exposures we've had in the past, and all of those things matter. Imposter syndrome amplifies the lack of representation, and the prove it again bias, specifically for women and minorities, it really affects the trainee experiences, which over time really talks about this allyship in surgical training, which it could look really different in practice. And I know some of the comments earlier about like, what are we doing to get our trainees to get to the right job? And that just really matters. All of these disparities will show up in the day-to-day for trainees, in the OR, in evaluations, how the trainees feel, whether they feel supported, seen, and valued as well. We've done a lot of work, again, to try to recruit these people and diminish these disparities. But still, we're not seeing that major difference. So inviting trainees from racialized backgrounds into a hostile learning environment, either we intend it or not, negatively really affects the feelings of well-being, inclusion, and belonging, and increased burnout and attrition for these particular groups. So we really have to be intentional and really, do a lot of self-reflection. What are we doing right and what we're not? All right. Recently, we did a survey via the APDVS to kind of take a look at what the trainees perceive regarding disparities and inclusion in training. The positive thing is that actually most of the trainees say that their program have peers and faculty from diverse backgrounds. They do have that. And this suggests that efforts have been made to increase DEI awareness and reaching the trainees. Whether this perception of diversity is sufficient to support the success of trainees from all backgrounds remains unclear. And again, because we haven't seen that across. But despite of these positive perceptions, we're still seeing discomfort in discussing matters of discrimination, with over 1/4 of these trainees expressing feel of retaliation, lack of meaningful impact, etc. So there's a lot of work to be done. So why does it matter? Because we know equity and diversity matters. Diverse teams have better outcomes and innovation. Fair training access means more competent and confident surgeons. We want to do retention and diminish burnout for these particular groups. So this is just not a DI issue, because this really implicates and has significant implications for patient care. Diverse teams make better decisions, and trainees who feel supported learn better. So if we want the best vascular surgeons, we need to give everyone the best chance to become one in the right environment and identify what are those specific needs for specific learners. We have those hidden barriers, bias in evaluation, mentorship gaps that we know it's very important. We've heard, today, and we've had many data suggesting that mentorship is so important for a successful career, successful match, and successful, academic and leadership positions. And microaggressions and isolations are still present, and we still have to be aware that they're still there. Again, we have done a lot of work, but it will be kind of underproductive, really, to just not understand and not be aware that these things continue to happen. And we have also an uneven procedural exposure. There's enough data to suggest that trainees of color or minorities or different backgrounds do not get the same exposure as perceived as others. So what leveling the field could look like? Exposure and access, early pipeline work, mentorship programs specific for these groups, assessment reform with training faculty on bias awareness, and support and belonging, and not just getting them to your program, or what are we doing while they're during their training, what are we doing to get them to the right jobs. As we know, equity is not about giving in the same, but ensuring that everyone has the same chance to succeed. So it's really a call to action. We have to reflect on how we evaluate this group of trainees. Look at your mentor, and look at who you mentor and also who you don't. I encourage you and challenge you to get out of your comfort zone and seek out particular trainees that you may not think of mentoring in other circumstances. Recruitment is just the first step, so follow through. What are we doing through their training? And advocate for policies that promote inclusion. Now, in conclusion, we have to acknowledge that there are still disparities. Again, we're doing a lot of work, but they're still present, and it's just not in trainee, kind of like overlaps again with, PAD issues, for instance. Understand why it matters. We really need to commit to change and start where you are. Small changes in your programs make a big difference in the future. So imagine the future as a training environment that every talented learner can thrive and not just survive, and identifying those skills, those talents, and really self-reflect on what that is and how we can help them really makes a difference. Thank you.
Dr. Harris?
So, Gabby, that's an excellent talk. I think the question for many of the people in the audience is, how do we become an ally for someone who doesn't look like us? So for women, it's gotten much better. There are more of us.
Absolutely.
But for a lot of the other underrepresented groups, if I have someone who is underrepresented, how do I do it in the right way? Because people who want to do it are trying, and we're still probably failing in some ways. So how do we make it comfortable for the trainee to say, you're trying, but you're not doing it right, or hook them up with the right people? Any thoughts on that?
Yeah, that's a great question. And I think that's where we are trying too hard at times. The more we look into this, representation matters. I wish it wasn't, but I think we feel drawn, just like patients feel more comfortable being taken care of by physicians and surgeons that look like them. I think the representation of that being your faculty matters for trainees. So I find that some of these minority groups feel maybe more comfortable discussing certain things or feeling that their mentorship may be more impactful than it may be someone that doesn't specifically look like them. That being said, the power of the mentorship of everyone that doesn't look like you, it's very important. So it may not be that it's someone that looks like you, but in terms of quantity, if you can have more people that is actually intentional about mentoring and not just saying, oh, I'm going to just mentor someone just because, but really be intentional, really be supportive, I think that matters. And also looking for, if you don't have that in your faculty, looking for other programs that may have that representation and people that are known to be supportive of these groups.
Great, Gabby, thank you very much.
Sure.
I think we're going to move on to the next session. So I guess we can call up the moderators for the next session to come up.